Hello, everybody. My name is Tahir Masood. I'm a professor of geriatrics in Nottingham, the UK, and I'm the recent past president of the British Geriatrics Society, and I'm also on the European Geriatric Medicine Society Executive Board with a special responsibility for education. We have a great symposium lined up for you today with 3 excellent speakers and 3 excellent talks, which cover 3 different important areas within the overall education framework. Our first talk is going to be on undergraduate education in geriatrics, defining competencies and the importance of international curricula. The speaker is Professor Andreas Stuck from the University of Bern in Switzerland. Professor Stuck is an academic geriatrician. He is the past president of the European Union of Medical Specialists, the Geriatric Medicine section, and he's the current co-chair of the EU GMS Special Interest Group on Education. The second talk will be on development of competence-based curricula for postgraduates in geriatric medicine. The speaker will be Professor Regina Rohler-Winsberger from the University of Graz in Austria. Regina has a long-standing interest in geriatric training and education and is widely published in this area. She is also a former chair of the EU GMS Special Interest Group in Education and Training. Our last talk will be on, is there a need for an international postgraduate examination in geriatric medicine? The speaker will be Dr. Michael Vassallo, who's a consultant geriatrician in Bournemouth in the United Kingdom. Michael is the Vice President for Education and Training in the British Geriatric Society. And he is also a previous chair of the exam board for the Specialty Certificate Examination in Geriatric Medicine, which is run by the Royal College of Physicians in the UK. He is also the current co-chair of the EU GMS Special Interest Group in Education and Training. Hopefully, we will see the 3 talks one after the other, and then we will have 15 minutes or so for a lively discussion. And I look forward to chairing that session, and hopefully all the speakers will be able to answer all your questions and we can have a nice discussion. Okay, so over to our first speaker now.
Dear colleagues, I would like to thank you for the introduction, and my talk will be about undergraduate education. Why do we start this series with undergraduate education? We are all convinced in geriatrics that this is most important, because geriatrics is not a subspecialty for doctors after medical school, but basically each doctor should master basic competencies in geriatric medicine after medical school. An orthopedist, an ophthalmologist, whatever the specialty is, we do not know what this elderly man needs as medical care. Each doctor should be prepared. And a special chance is during undergraduate medical education, when geriatrics can contribute basically to better care of older people by future physicians. I would like to present to you some experience we have from a European perspective. And a basis of my presentation is an earlier work of a Delphi consensus process that we conducted in 2012 to 14. And based on this Delphi process, we defined learning objectives as a consensus in geriatric medicine, which we thought are minimum requirements that students should achieve at the end of medical school. And as you can see, we were a very heterogeneous group with 29 European countries represented, with experts all having different healthcare systems. And we just try to identify what are common goals physicians across Europe in these different healthcare systems should actually master. And this has been a big success. You see that this curriculum is now available in multiple languages, available on our website of the UMS Geriatrics Medicine section, which is the European Union and European, basically, organization for the specialty of geriatric medicine. We identified as part of this curriculum 10 key domains, which we thought were especially important in terms of teaching geriatric medicine to undergraduate medical students. It starts with the aspect of patient respect, with basic principles such as aging principles and normal aging, and then continues with more clinically oriented domains and the healthcare system. Our educational framework was the knowledge, skills, attitude framework. And as you can see with some examples in the aging principles, we then, under this objective, stated that we expect students to be able to describe the pathophysiology, diagnosis, assessment, management, and so on of common geriatric syndromes, and then listed these syndromes to be very specific about the contents of geriatrics. For geriatric assessment, for example, the focus was on expecting certain skills from medical students. For patient respect, of course, it was rather attitude. And this educational framework is still being used by many international curricula, such as by the UK educational framework, which is not on geriatric medicine, but overall. And in these outcomes for graduates, you can also see that there is a classification according basically to attitude, knowledge, and skills here. But again, we would like to know what is now specific about geriatrics. And since our consensus was conducted in 2014, we were interested in knowing what has happened since then. And colleagues, in a group of colleagues under the lead of Tahir Massoud, who is chairing our session, with Giulia Oliari and colleagues, and you will recognize that speakers today, like Katrin Singler and Michael Vasalla, were all also involved in this scoping review exercise. We identified more than 300 articles dealing with this topic of basically undergraduate training in geriatric medicine. And I think an impressive finding of this work by Tahir Massoud and colleagues, which is published in the European, you can see here, Geriatric Medicine journal, was basically the frequencies of terms in which those authors were interested. And one of the key topics was apparently attitude. And I think this is no surprise. In geriatrics, of course, we are very much basically concerned that students might basically, if we do not draw that attention of students to older patients, might not sufficiently basically have a sort of professional attitudes, which is basically as seeing the professional work with older patients as a key work, and also as older patients as a patient group deserving special respect, and therefore also communication and interaction skills. So a lot of literature has also been devoted to this attitude towards elderly people. It was interesting to see that there were some key emerging curricular topics, such as in clinical work. Frailty, for example, emerged as an important topic, but there is also increasing work on teaching students on delirium, telemedicine, especially over the last years with the COVID-19 pandemic situation where telemedicine was an approach additionally used in teaching, and which is not only used in teaching but also as a method for caring for all the people if they would need care by telemedicine. Healthy aging and health promotion, another topic. Now about teaching methods. There are these very different teaching methods that are used by these new articles and mentioned, and you can see that there are multiple methods that can be used in undergraduate medical training. One of the new methods that you identify on this list is the EPA approach, and I would like to briefly introduce the EPA approach to you. Many of you might be familiar with this approach. It is the entrustable professional activity. And because we were especially interested in how you can apply this approach toward in undergraduate medical education and geriatric medicine, we also conducted a systematic and scoping review on this aspect, publication which will soon be published in Aging with this title, with Taslem von Streng-Paltz as the first author. And we defined again what an EPA is. It is a unit of professional activity that can be entrusted to a sufficiently trained learner. So examples of an EPA, so that you can have a picture of what an EPA is. An EPA is, for example, the ability to obtain a history and perform a physical examination adapted to the patient's clinical situation. So if you have this EPA, then the expectation is that an expert observes a student while doing such a task in a patient, and then decides whether or not he or she can trust the student to do this. And there are various entrustment levels, and the typical entrustment level which is expected from a medical student at the end of medical school is to be able to act with indirect and reactive supervision only. So the student should be able to do the task without someone on his or her side directly. So the student should be able to do that alone in a room, but closely available to the student, there should be someone with more clinical expertise to help if needed. So if a student then is being observed obtaining a history, the expert will see, is the student performing in a way that he or she thinks in the future he or she can send this student to a patient in another room and can trust the student that he or she is doing a good job in obtaining that history. So something which is very fundamental basically to our medical profession, and which is something which is easily comprehensible by medical teachers and highly appreciated by medical students who are exposed to that kind of system. Let's take an example of the EPA: formulate, communicate, and implement a management plan. That is another EPA. Now, my question is, in what setting should a student demonstrate an entrustability? And it is interesting that in our systematic review, we found 9 international curricula including EPAs. And we found that most of those curricula said, oh, we expect medical students to formulate these management plans in the acute setting and in the primary care setting, but only a small minority expected that students are able to do that in the long-term care setting. You see, again, the long-term care setting neglected. Then the other question is, in what patients should students demonstrate entrustability? In what patients? So again, it was interesting to see in our systematic review that only 3 curricula explicitly said, oh, students should be able to do this and should be entrusted and be observed while doing and proposing a management plan to a multimorbid older patient. And 6 curricula did not mention this, or in some cases even mentioned that typically it should be to a sort of middle-age, medium patient with not too much complexity. So you see already on the level of the international curricula, including EPAs, there is an unclarity on how the basic principles of geriatric medicine are integrated. And here is a summary of key deficits we found in those curricula, including EPAs. Normal aging is sometimes neglected, geriatric assessment domains. Decision-making capacity assessment, very much neglected, and as mentioned, care in the long-term care setting. So, on the other hand, these model curricula also showed that EPAs can be a model on how actually to formulate curricula and to teach geriatric medicine, because you can specifically define that an EPA should require specific knowledge, skills, and attitude with regard to geriatric medicine and to do this. For this purpose, I'm now coming to the conclusion. If we want to make undergraduate education in geriatrics fit for purpose, we need to update curricula and make sure that previously neglected domains have a better coverage, and that these curricula should then be implemented. And we think that the EPA approach has a potential value because it forces university and teachers to answer the question, do we think that we need future doctors who can be trusted to care for an elderly multimorbid patient in a nursing home with distant supervision? I think the answer is yes, but many universities have not yet answered this question, and we think we need curricula that basically address this issue, because geriatric medicine is a supra-specialty and not a subspecialty and deserves adequate attention by all medical schools internationally. Thank you very much indeed for your attention.
Thank you for the kind invitation to join this symposium. We will now move on to postgraduate education in geriatric medicine and the current trends ongoing in Europe. I do not have any personal conflict of interest for that talk, nor do I have any conflict of interest financially. Before we get started, I would briefly like to guide you through the agenda of my short talk. I would like to talk about the challenges for education and training of health workforce in this century. I would like to guide you from medical school to postgraduate training, namely from learning objectives to developing professional profiles as doctors. Then I would like to introduce you to the new European training requirements to become a geriatrician, and probably focus a bit on benchmarks across the countries, and finally sum up my talk and my content in a short take-home message. So let us get started. This IAGG World Congress perfectly outlines focuses on the current health challenges ongoing in our century. And those challenges to healthcare systems are very complex equally around the world. We have increasing health inequalities, and we have, especially in the Western countries, a demographic shift towards aging societies. Accordingly, or in line with this, come along environmental threats, like on micro level of the people living in the countries with increasing rates of obesity, alcohol misuse, especially in the US, the challenges with narcotic drug use, but also the major disease outbreaks we have been facing over the past 2 years. All those threats are putting financial pressure on health and welfare systems across the globe. And everybody is struggling to include social and technological transformation within healthcare. Accordingly, with migration and geographical shifts we are facing in the US as well as in Europe at the moment. Given this situation in the 21st century, we have challenges for healthcare that are disruptive trends that are beyond our control in reshaping our healthcare systems, and reactive trends trends that are emerging as a result of the disruptive trends and must be acted upon quite soon, otherwise a healthcare system will break. Disruptive trends include aging societies, include the trend towards digitalization, personalized care processes, as well as patient empowerment. The reactive trends we are seeing in the clinical medicine are a focus on prevention and prediction of diseases, especially the challenge in managing chronic diseases in the Western world, and the implementation of remote healthcare. When we talk about health workforce, when we talk about geriatric medicine, we talk about a changing profile of skills needed by health workforce for the near future. And those skills are generally based on the trends within healthcare system transformation. Only by knowing what skills are relevant for the future, we will be able to teach the future health workforce, thus upholding also, especially in Europe, our innovation capacity in the European markets. To plan and to act upon health workforce development, it is necessary to see healthcare within a whole ecosystem approach. If you go to the picture I have brought with me in this slide, in this very center, you see the patients and the citizens we are working with. And those patients and citizens, dependent on the country you work in, they live in distinct health and social care environments. We have companies acting, we have policy making plans for healthcare, we have funders to be able to translate and to offer healthcare. We have the third sector also included into healthcare. And we as universities have a strong demand to educate people working in all these ecosystems and to do research that allows us to support and to evaluate the transformation processes we are guiding through. So wherever you work, before talking about health workforce development, we need to know which ecosystem you are working in and what are the needs for the future health workers to work within those health and social ecosystems. So workforce policy and planning, regulation and management are aligned with service planning and service delivery and support integrated teams rather than isolated individual health professionals, effectively addressing non-communicable diseases and all the disruptive and reactive trends I've shown to you before at all levels of service provision within each ecosystem across the globe. And when you educate and you train healthcare professionals, you have to define core competencies that are needed to work in those future transforming healthcare systems. These competencies will be manifold. They need to have a patient focus. They need to have a practice focus for professional standards and ethics for ecosystems on national or international level. They should have, in terms of reactive trends, especially for non-communicable diseases and frailty prevention, for instance, a population and a social focus. And of course, the future health workforce needs to have skills in management and organization to translate all the processes they are doing with our patients, also in digital tools and in data generation, to allow artificial intelligence learning systems to further support us in the future. And this now brings us to the model of competence-based medical education. What is competence-based medical education? It has a focus on a predefined outcome, a profile. A healthcare worker or a geriatrician must reflect in the near future. It has to have a focus on students and doctors' abilities more than knowledge, which is very often still trained in academic institutions, training doctors, nurses, dietitians, and allies working within those healthcare ecosystems. Medical competence-based medical education is learner-centered, and it is de-emphasizing time-based learning, segmented learning, and assessment towards a more goal-oriented and learner-centered approach. In this current context, becoming a geriatrician is very challenging, and we need geriatricians across the globe. We do not have many of them. And the European Union Geriatric Medicine section at the European Commission decided to come up with new training requirements to become a geriatrician in Europe. They were signed some years ago, and those European training requirements outline minimal training requirements to become a geriatrician in one of the countries across Europe. The framework of the European training requirements allow possible national adaptation and alignment within the workforce capacities needed in the signing countries who designated themselves to use those new European training requirements. What we have been doing was shifting from learning objectives to more professional profiles within these training requirements, implementing competency-based education. And this competency-based education is more on a tangible capability to perform an action on workplace as outcome of education. And competency-based medical education is an approach of preparing physicians to participate for practice, what is fundamentally oriented to graduate outcome abilities and organized around competencies derived from an analysis of social and patient needs, as I have outlined already before. We have created a framework that is built on entrusted professional activities, as I've just described to you. So these EPAs, these entrusted professional activities, are merely units of work that we are doing in daily practice as medical doctors. And if I describe an action in workplace, I can then better identify at what stage of your training career, and my colleague Professor Stuck has already outlined that in the talk before, a student or a medical doctor is able to perform this action in a workplace either by himself without any supervision at the end of a training career, or like at the very beginning, needs support and needs to be shown what has to be done. The structure of these EPAs, of these entrusted activities in workplace, is given by the AMI Guide on Medical Education. Each EPA has to have a title, a specification and a limitation, and it covers the most relevant competencies within the framework of expert, health advocate, communicator, scholar, collaborator, professional, and manager, like outlined in the CanMed role model very recently. It describes required experience, knowledge, skills, attitudes, and behavior. And it also delivers the information how to assess the learning outcome of a patient and the sources where summative and trusted decision-making may be outlined. It describes the entrustment, for which level of supervision is to be reached at which stage of training, and it also includes expiry dates. The European training requirements to become a geriatrician has different levels of competencies. The basic level, like outlined by Professor Stuck before, is the level at the medical university or faculty level where students have observed things or can do them with assistance. More advanced is to do but needing assistance. And within the postgraduate level, you will find the level of competent to do without assistant, or be able as an entrustable professional activity to teach others how to perform a procedure. So this is the highest level you may reach during training. Within the European Union, we have defined 12 entrusted professional activities that every geriatrician must be able to perform at the highest level of competencies, and the level of competencies has to be predefined within the curricula, the national curricula. So these EPAs just represent the basic core competencies needed. And this framework allows every country across Europe to adapt and to form a deeper granularity within their curricula based on these EPAs. So in the national curricula, we need to know how the training is organized, how the assessment evaluation is performed, and how the minimal core competencies are reflected in terms of their level of competence. And every 6 months, the trainees have feedback discussions, either if they have targeted their training goals, or they will need intensified supervision, or it may also happen that trainees are withdrawn from their program and have to choose for a different orientation in their clinical practice. We have also outlined the assessment methodologies. We use mini-secs. We use directly observed procedural skills, case-based discussion, multi-source feedback, also patient feedback from in and out patients, teaching observations, and also the EPA evaluation. Around the clinical training, we also ask the training providers to offer additional offers, such as case presentations, lectures, grand rounds, like used in the US for many, many years, exercises in clinical skills centers, critical appraisals, research meetings, or interdepartmental education. This already brings me to my take-home message. Recognizing the need to prepare health professionals for meeting the dual challenges of technically and emotionally complex healthcare workplace is a prerequisite for building and maintaining a resilient and a resourceful health workforce. It has been important to define a new competency framework for geriatricians who work in very diverse healthcare settings in Europe. Giving the design of the new ETR allows the harmonization of training content and training environments across European countries, ensuring that geriatricians of the futures are fit for purpose within the next generation of healthcare systems. I thank you all for your attention.
Good afternoon. I would like to start by thanking the organizers for inviting me to give this presentation. My name is Michael Vassallo. I'm a consultant physician at University Hospitals Dorset in the United Kingdom. I'm Vice President for Education and Training of the British Geriatrics Society and co-chair of the Special Interest Group in Education and Training of the EU GMS. The subject of my talk is there a need for an international postgraduate examination in geriatric medicine? Before I start, I just need to make a declaration of interest, but also a declaration of experience in this area of examination. I am currently Senior Examiner of the Diploma in Geriatric Medicine, which is run by the Royal College of Physicians of London and the British Geriatrics Society. And I was also Chair of the Special Certificate Examination in Geriatric Medicine between 2010 and 2017, an exam run by the Royal Colleges of Physicians in the United Kingdom and the BGS. The aims of my talk are three. Basically, I will leave the need to develop an exam as the last question, but before that, I will speak about the challenges of developing a postgraduate examination and also the processes of developing an exam, particularly the European experience of developing this exam. So, going forward, to start off with the challenges of developing an exam in geriatric medicine. There are many, and I would like to classify them into two. One of them, the academic challenges, and the other one, infrastructural challenges. So academically, one needs to answer, what does the exam want to achieve? Is this an exam, an exit exam to certify that somebody is competent to treat patients independently? Is it intended for people who are working with distance supervision? Are they doctors? Are they nurses? Or are they multi-professional people? Like, for example, we have the diploma in geriatric medicine. So that's another question. Who is the exam for? How does the exam link with prevailing curricula? The exam needs to test something. So a lot of these things that need to be tested are predetermined in various curricula or syllabus, and therefore the exam needs to be tailored to those. One needs to decide the format of the exam. Is it going to be a written exam? Is it going to be a clinical exam, or is it going to be a combination of both? And another important thing to determine is the blueprint. The blueprint is a document that determines the format of the exam and what are the relative weights of various things that need to be tested in the exam. For example, how many questions on biology of aging, how many questions are there going to be on acute care, how many questions on clinical care. So this is determined by the blueprint. The next important thing to run an exam is the infrastructure. It is very complicated to run it. You need a body that is able to deal with the application processes, advertising, dealing with complaints, dealing with academic misconduct, dealing with appeals. And you need to have a robust rule book in order to be able to do these things. Developing the exam is not a question of a few people sitting around the table and coming up with questions. There are various subgroups to doing it, question writing groups, exam boards, standard setting, etc. I will mention these later. One needs to develop links with regulatory bodies. If an exam is an exit exam that determines whether somebody can function independently in treating patients, then regulatory bodies like in the UK, the GMC would need to be involved and is actually regulating the exam and setting the rules for it. And finally, the quality assurance aspects of it. How do we know that the exam is actually fit for purpose and achieving the goals that it's set out to achieve? So basically, what can an exam achieve? A written exam, to start off with, is a test of knowledge. So basically, that is the main thing that the exam tests. And this is knowledge in terms of clinical problem-solving skills, knowledge about various diseases that exist that need to be known about, ability to diagnose, and ability to demonstrate clinical reasoning, pharmacology, and evidence-based medicine, and also knowledge of guidelines. A written exam complements work-based assessments. So for example, for an individual to be certified as a trained geriatrician, it's not a question of knowledge alone, but it's also knowing that the person concerned can apply that knowledge to day-to-day care. And that is assessed on the ward in the job. And this is the whole point of work-based assessments. And the written exam just certifies the knowledge aspect of that. Also, the written exams provide standardized national or international assessment to establish public confidence and approval of regulatory bodies. And at an individual level, they drive learning and develop and encourage acquisition of knowledge and experience in each specialty. Conversely, a practical exam or a clinical exam does sort of test another set of skills, and these are the generic skills that we all have to use when we are taking care of patients. These are skills which are such as doing a physical examination, identifying physical signs, communication, determining a differential diagnosis, clinical judgment, managing patient concerns, in discussing with the patient a management plan that is acceptable both for the clinician and both from the patient, and maintaining patient welfare, ensuring that the patient is safe at all times. But apart from these generic skills also, an exam can be used to test specialty-specific skills. Like for example, in the DGM, we have a comprehensive geriatric assessment station. And there is sort of plan to develop new clinical scenarios based on geriatric syndromes such as falls, cognitive impairment, etc. So there's a lot that can be achieved by examination and at what is tested. And I'm going to speak briefly about the European exam experience. We all know about the demographic reality associated with increased longevity and the need for geriatric medicine. Across Europe, about 70% of member states recognize geriatric medicine as a specialty. but there is a wide range of ways how geriatric medicine is practiced across Europe. And basically, however, having said that, despite these differences, core components and the requirements of the specialty are the same, and there is a considerable amount of common ground across various countries. And in many ways, you know, step number one in trying to set up an exam, as I said, you need to test something, is setting up a European-wide curriculum. And you have already heard about this study from my previous speaker, Andreas. And basically, in this process, this was a Delphi process to set up a European postgraduate curriculum in geriatric medicine. There were 32 expert panel members from 30 different countries participating in this process. And basically, the long and the short of this paper was that there were 4 domains that were determined and as common across the board. And these were the need for quality indicators of training programs, the requirement of knowledge for inpatient care and outpatient care, additional skills and attitudes required by a geriatrician, good communication, comprehensive geriatric assessment, and also the need for assessments of a geriatric postgraduate education. So the final one was assessment, and therefore, stemming on from this, you know, the aim was to try to establish some form of examination. Now, a lot of the work-based assessments happen on the shop floor in various countries, so there is a lot of regional and country-specific ways of doing things. But as I said, there is a need to assess knowledge. Knowledge is going to be the same whether you are in country A or in country B. But it's difficult. It's not easy. So the options were either doing nothing, and it was decided at the highest levels in various societies in Europe that doing nothing was not an option. So the other thing that was considered was certifying national exams where they exist. There were a small number of countries that hold their own examination. And one option was considering whether these could be accredited in some way. But this was not considered as something that was academically robust for various reasons. And the final option was that of using an exam that is already running. And out of all possible contenders, the UK exam was felt to be the most robust and run by an organization that had lots of experience already. So we're lucky in the United Kingdom that we have the Royal Federation of Royal Colleges that has been running exams for a huge number of decades now, and has lots of experience and the infrastructure to do it. So I'm going to speak briefly about the process of running an exam. As I said, it's quite a complicated process, and there are these 4 main stages. So I'm speaking about the written exam here. So the first step number is question writing, and in question writing, sort of the question format is a best of 5 format, which is, you know, a wrong answer is not the best answer. Basically, the question is seeking to find out the best answer that there is, and the questions are written up by various members. And I must say to all the members that work on various committees and groups do this free of charge. They don't get paid for it. These questions cover the curriculum. They need to be covered the curriculum, and they are all peer reviewed at the question writing stage. When these questions are agreed after a peer review, this first peer review, then they are going into a bank, and then the job of the chair and the secretary is to choose questions from this bank to move into the paper setting stage. These are going through the exam board, and then from the exam board, they are standard set. So the paper that is agreed at the exam board is standard set, and then the exam is held, and then there is a post-examination review. I will say something briefly about standard setting. basically, you know, a lot of the theory behind this is item response theory, where the main aim of a written exam is to distinguish between candidates. The good candidates and the bad candidates are easy to determine. However, what is more difficult and what is the focus of the standard settings group is the just passing candidate, the one who may just pass on this occasion, but on another occasion may equally fail. And we all know this person. Sort of, we probably have an idea of somebody in our head. However, this is what the question. So when the group on the standard setting need to determine is this borderline candidate, should they know the answer to this question or not if they are borderline? And that is how the mark is set. And then ultimately those accumulated marks from the standard setting group then are used to use an Angoff's method and a Hofstee correction in order to set the final pass mark of the paper. There's no time to go into the detail of this, and basically this method set acceptable bounds for both the pass rate and the pass mark of the exam. And this is allowed to fluctuate within defined limits depending on the number of candidates. But once the exam is held, then there is a post-exam analysis, and basically the questions that are performing badly are reviewed in order to make sure that they have been fit for purpose. And when it comes to calculating the final mark, they are removed if they weren't fit for purpose. So the aim is to not to remove the any questions, but maybe 2 or 3 of them might need to be removed if they have performed badly. So as you can see, there's a lot of work to be done across various stages. So finally, then back to the original question, is there a need to develop an examination? I would say yes, wouldn't I? Some of you would obviously say, but I would say yes for various reasons, because it validates the effectiveness of training programs, it quality assures stakeholders, raises the standard, supports individuals if there are no training programs to benchmark themselves, and provides an opportunity to develop a multi-professional workforce. It is not easy, and therefore, you know, there's going to need to be a lot of effort in trying to establish an international exam, because first of all, you need to establish international minimum requirements. You need the infrastructure to run it, and it's good to see who does it and who does it well. And it's difficult to start from scratch, as I said, but you know, to partly quote John F. Kennedy, we do these things not because they are easy, but because basically it improves the standard of what we do. Thank you very much.
It's a very good question, because in our recent scoping review that Andreas talked about, there was a lot of papers being published in the last few years, actually, explaining how useful environments such as nursing homes can be in geriatric training of medical students. And there have been some very successful schemes across the world utilizing care homes as a place where students can go and learn geriatric medicine. So it's a great question. Thank you very much for that. While we wait for other questions from the audience, and I would encourage the audience, please do send in some more questions. Can I come to you, Mike? Now, you talked about developing, you know, an international exam, and you gave us the experience of trying to develop one across Europe. But I presume you're talking mainly about a written exam. You mentioned the MCQs and so on. But what are your thoughts on whether there should be an element of a clinical exam, either in place of or as well as the written aspect?
I think the difficulties that exist in terms of developing a written exam exist, and they are the same for developing a clinical exam. One needs to agree standards across Europe. One needs to check what does a clinical exam want to achieve, who is it intended to. So there are various issues relating to that. However, there's a degree of Europe-wide commonality in terms of what clinicians do in terms of physical examination, formulating differential diagnosis, formulating management plans, communication. There's a lot of commonality across Europe. So I think it is possible. But again, you come back down to the difficulties with it, the infrastructure to organize it, and you know, the curricula and what it is going to achieve. So I think it is possible. At the moment, a lot of these clinical tests are sort of tested in various countries, and there's, I think going forward, I think it is something else that one can work towards. I think, however, a step at a time, I think, first of all, I think it will be good if we can get and establish a written exam across Europe, and then we can make another step forward once that is successful.
Okay, if I can carry on then while we wait for other questions. Obviously, geriatric medicine is developed very differently in different countries across Europe, for example, and I presume across the world as well. So, I mean, what are the challenges with regards to that in developing an exam such as a European exam? For example, just to give you an example, for example, stroke medicine in the UK is often carried out by geriatricians. So training in stroke medicine is a vital part of geriatric training in the UK. And I'm aware in other countries, for example, stroke management is purely done by other specialities such as neurologists and so on. So does that create problems in trying to sort of harmonize an exam across countries?
It would definitely create a problem, and this is the big problem: is how the specialty is practiced in different countries. And as you say, in one country, in the UK, stroke is done by geriatricians, but even then, that is going to sort of possibly change going forward, because neurologists with the new curriculum are going to be doing stroke as an integral part of their curriculum going forward. So that may change in the years to come. I think, as I said, that is one of the biggest difficulties, is how one can have an exam that suits everybody. And therefore, obviously, one needs to find what is common for everybody, which is knowledge, and which are the basic things that one does in assessing patients, and sort of work on those common areas in order to develop the exam. But as I said in my talk, it is not easy.
Okay, all right. Thank you. So we have some questions coming up now. Excellent. Keep them coming. So there's a question from Anna Kamaid. Excellent conference. Thank you. What about the geriatric teaching for workforce? Do we also, or should we also teach the teachers? Andreas, do you want to start with that? I mean, shall we develop a curriculum for training the teachers in geriatric medicine?
Absolutely, and I think this is a very essential role of geriatrics, to be the teacher, for example, in undergraduate medical education, but we could also speak about interprofessional training. We could also speak about postgraduate training for doctors in other specialties. And I think here, not to have recommendations only, but to have examples or a sort of tutoring or offers with possibilities on how to do that teaching with sample presentations and so on might be an important role of geriatrics to contribute to distribute the knowledge and skills and competence of geriatrics across different disciplines and professions.
Okay, Mike, do you have any comments on that one?
Not really. I can't really add much to what Andreas has said. No.
Okay. I mean, one thing, if I could come in. So our scoping review recently also said that there are a lot of different ways to treat undergraduates. Just as an example, the flipped classroom. And I think training the teachers about the various ways you can teach undergraduates can be quite useful. For example, the flipped classroom means that you give the students some homework first to do, and they go and read about the topic, and then in the classroom, in the session themselves, you don't actually teach that, but you reflect on it, you discuss it. So in a way, you do things the other way around, and that has been shown in recent papers in many institutions to be quite a useful way of doing it. And there are many other ways as well that you can teach students as well. Virtual methods, for example, they're becoming more and more prevalent as well. Okay, there's another question from Moises Shapira. Andreas presented attitudes towards care of the aged as an important topic, but how do you measure this objectively?
In the EPA approach, you can give professional feedback as a model teacher.
Okay, so that's another usefulness of the EPA approach there. Thank you very much. Okay. Right, well, sadly, I think we've come to the end of the hour. I've been told that I have to stop now. I'd like to thank you, everybody who've joined in. I hope you've enjoyed it. I think there were 3 excellent talks, and we had a little bit of time for discussion in the end. I think I am told that after June the 22nd, this whole session will be available to be reviewed again, and will be up for 90 days. So if you have other colleagues who have joined the IAGG and registered but weren't able to join this particular session, they can join it later on, and they have 90 days to do so. So thank you very much to all the speakers. Thank you to Andreas and Mike for staying and coming and joining the live chat. Sorry if Regina can't be there, she sends her apologies. And thank you for the audience again.